Good morning, everyone. I hope that you can all see and hear me okay. Could I just ask you to show some thumbs if you can see and hear me all right? Brilliant. I'm just watching the numbers climb up, so we're just going to get started because we're expecting a big audience and we've got a lot to cover. So thank you so much for joining us today. And we're really pleased that you've been able to take time out of your very busy diaries to sort of contribute and hear some fantastic speakers today. We're going to ask that all of you mute your microphone and turn off your camera, including our speakers, and we'll invite you to come in at the point that you're going to cover your own presentations. While we're waiting for everyone to join, there's going to be a poll that will pop up on your screen for a couple of questions. And we're really interested in you answering these, and hopefully you can take a wee moment to do that before we get started. We're keen to understand in what capacity you're joining us and what are your interests in joining us. It helps us design the future webinar series, and it helps us understand exactly whereabouts in the system that you're operating in, and therefore the benefit of a webinar series. So if you don't mind, if you could take a wee moment to just complete those questions, I'd really appreciate it. And in doing that, I'll take you through a little bit of an introduction and get us started for our session today. So it's up to me to give you a bit of a welcome and introduction. So welcome everybody. In terms of any technical difficulties, if for any reason you can't hear us or see us, please leave the call, and if you email us on his.matt@nhs.scot, and that information's in the chat, we've got a team who can do their best to try and get you back online and make sure that you can get access to the session. Generally, our housekeeping is that we ask that you mute your microphone and switch off your camera for the duration of the session. It allows us to protect the capacity for everyone else to sort of hear and see us okay. The session will be recorded and it will be available on YouTube later on, but we will alert you to that once it goes live, and you can share that information across your networks. We'll utilise the chat function today, and we're really interested in hearing from you as an audience, and so please engage in the chat. If anyone's asking questions that you think you've got a contribution to make, please do that. It's an excellent way for us after the event to go back and see the kind of interesting conversations that were happening, or where people were generating connections or offering insights for colleagues in relation to the work that they're doing, but also where they can support the work of others. So, I mean, for all of us who are connected to drug and alcohol, we absolutely recognise that working within this space can often or can be quite triggering for people. So it's important that you just take some self-care. We recognise that this is an emotive subject area, and today's session will cover personal experiences in relation to drug and alcohol and critically recovery, and that might be upsetting or triggering. So please take care of yourself, and if at any point you want to step away, please feel free to do so. And if you'd like to pick up any comments or questions about the content of the session, you can reach us at the his.matt email address, and I'll pick that up myself if there's any specific reflections or questions you have. So please do look after yourself, because it isn't an easy subject area, and sometimes I think we forget that actually we're talking about real lives and the people who are affected. So it's really important that we give them the respect that they're due, but also we look after ourselves in doing so. So let's go into the guts of the session today. So we have been for some months now working with some excellent allies and colleagues who you'll hear from today about the importance of recovery. And I think it's really critical to recognise that Scotland's facing a bit of a movement just now in building on the excellent progress and work that's been happening in relation to recovery from addiction. And so we really wanted to take the opportunity to reach a really broad demographic of people who work across health and social care to bring that to life and to share what we've been hearing about and also what we've been inspired by in terms of the future direction as we hurtle towards the end of the current phase of the drugs mission. So today our session has been delivered in collaboration with Harbour Ayrshire, and you'll hear from them the powerful role of recoveries within communities and their experience of trying to support people to thrive. And I guess that's part of the reason for our webinar being titled Alive to Thrive. The idea being that oftentimes in our development we've been looking at just protecting people and keeping them alive, but the reality is we hear from recovery communities there's so much more capability in making people thrive and helping them to thrive and the loved ones in our community. So that's what this is all about. So today we've got a fantastic group of speakers who've been in the background preparing for your session today. So from Harbour Ayrshire, we've got, who some of you may already know, we've got Eddie Gorman, who's the project manager down there, Vicky Borland, the volunteer coordinator, and Megan Brown, who's one of the family support workers. And you'll hear from them about the shelter from the storm of addiction and their experiences in trying to support people in recovery. And then later on, you're going to have Professor David Best, who's the Director of Star Recovery, amongst many other accolades, and Dr. David McCartney, who's a addiction medicine specialist and a subject matter expert for us within Health Improvement Scotland. Eddie, Vicky and Megan will start by sharing an overview of the work that they do at Harbour, the impact they have in supporting people through their recovery, and the role that they have in helping individuals reintegrate back to their communities and the transformational impact that has. Then we're going to have a short break, allow you to refresh your cuppa. And then afterwards, we'll have Professor David Best and David McCartney alongside Eddie Gorman talking about the role of addiction and addiction recovery services, and what we need to do to mobilise communities and mobilise recovery. So it should be a really interesting conversation, and please use the chat. We want to get as much out from the audience as we possibly can. So without further ado, I'm going to welcome Eddie Gorman onto the screen. Eddie, if you want to come on and say hello, so I know that I can hear you okay.
I can hear you fine. Ruth, can you hear me?
Brilliant, Eddie. So I'm just going to welcome Eddie, and then Vicky and Megan will join us at the course of your presentation, and you're going to take us through a bit of a presentation about the shelter from the storm of addiction and the work that you do at Harbour. You guys are going to share the work that you do, and we're really interested to hear more in the comments about reflections and thoughts about that. So Eddie, over to you.
Thanks, Ruth. I'm just going to share my screen with you, if that's okay. If you can let me know, can you see that okay?
Can do, Eddie. Yep, brilliant.
Yeah, perfect. So, as Ruth says, I'm Eddie Gorman, the project manager. I'll give you a quick overview, and then I'll tell you a wee bit about the work that Megan and Vicky's doing in our community. Is a great work they're doing in there. So it's really good to be here. Thanks for having us. So why does Harbour Ayrshire exist? So two of our founder members, two local businessmen, Clive Kennedy and John Gilardi, had seen the impact that the drugs and alcohol was having on the local communities, and they decided they wanted to do something about it. So they came to me and asked what we could do in our local community to help that, to reduce that impact that was having, and we created Harbour Ayrshire. It's rooted in lived experience, and we believe that everybody, recovery is possible for everyone. So when I was asked to do this, I spoke to Carrie and I asked her, what message is it you want me to get across here, Carrie? And she says, look, I want to hear some human stories. I want to see the impact you're having. She says to me, what gets you out of your bed in the morning? And which is a great question. And I said, well, I'm a very privileged person. I'm in recovery myself, long-term recovery, and I'm very privileged to have this role that I've got at Harbour Ayrshire. It's get to see some brilliant outcomes, some fantastic transformations in people's lives. I've got a great team that work around about us and support us. But also, I've seen the impact personally that addiction has on our communities, and also for the people we're supporting. And I want to tell you about John's story, and I hope this doesn't have an impact on anybody. And as Ruth says, I'll support thereafter if it does, because it's a sad story. And it's a boy we supported very early doors. So it's John's story and John's family story. So we tried to get John, and we got him to rehab in my first 6 months of Harbour opening. And we took him down to Leicester, drove through the night and got him to Leicester. And John didn't see his treatment in rehab, and he left, and he came back to Ayrshire and he relapsed. And sadly, John passed away, which was devastating impact on his family. And his family actually asked me to carry the coffin into the crematorium, which I was privileged to do. A lot was really challenging, because after I'd done what I had to do, I sat behind in the second row behind his family, and the wails of his mother, John's mother, grieving for her lost son. If I never hear that sound again, I'll be too soon. And really, John's story reminds us what's at stake here, what it is that we're up against, because we support people to thrive in Harbour, but they need to be alive for us to support them. And unfortunately for John and his family, that didn't happen. So that John's legacy fuels the determination, and that is one of the reasons that I get out of my bed in the morning to come and do what I need to do to help people, not just to help people thrive, to support people so they don't have to go through the same experience that John's family went through. What we do at Harbour, we've got 14 peer support groups. We've got men's groups, 4 men's groups, 4 women's groups. We've got 3 family groups, and we've got a mixed group. We've also got 2 groups in the hospital, and we've got a Zoom room for people who can't access face-to-face support. We've got a community support vehicle, which is an amazing bit of service. You'll see the picture there, the big white van, the big transporter that helps people who are fleeing violence or abusive relationships, and moves the homeless as well. So it has great service, not just for the people that's receiving the support, but also for our volunteers. We've got 60 volunteers. The volunteers are the mainstay of our operation. And when you come into recovery, there's a bit of guilt and shame about how you've lived your life. And with the volunteers getting to go and support people that's in crisis and help women fleeing violence and abusive relationships and stuff like that, they're able to heal for that guilt and shame. So it's a brilliant service. We've also got one-to-one support as well. We've got 3 recovery practitioners. We've got a digital inclusion officer, and we've now got Megan, who's a family support officer. And we've also got our helpline, which meets people at the time of needs. When people make the decision that they want to turn their life around about, it can be a very, very small window of opportunity. And we offer that time effective support with that out of our helpline. When the services close at 5 o'clock, our office number gets diverted to a helpline, and whoever's phoning the helpline number can get support, some resources, some signposting, and some out of our support for somebody that's at that place when they need. Psychologists call it a reachable and teachable moment. So the outcomes we've had last year, and Harbour Ayrshire had some absolutely outstanding outcomes. We had 52 people supported into residential rehab through our buddy service. We support people before they go to rehab, which can be a challenging time for people to get them away to rehab, while they're in rehab, and then when they come back into the community during that transitional period back into the community. 53 people in employment, 21 in education, over 189 calls to the Harbour helpline, and over 500 support people receive one-to-one intervention, and that's delivered by our staff. And there's been more than 200 people supported through the outreach vehicles. That's a community support vehicle, and we've got a minibus that helps people that can in rural areas to get to the face-to-face meetings and bring them into the bigger towns to access support. Why I think the Harbour model works. It's a trauma-informed practice, offering retention for not just for the people that's receiving the support, but also for our staff. And the second bullet point here is we've got a passionate lived experience workforce, which I think is absolutely vital for any service, because recovery's got to be attractive, and the staff that we've got in about at Harbour with a lived experience, they've got a passion for life, they've got a zest, and they really just want to help people. And that brings people in. But that trauma-informed practice is not just for the people that's receiving support as well, because we're a lived experience organisation. That brings its own challenges as well. So we need to look after the staff as well, and that's important for us for our staff retention as well. Harbour, 56% of the people that start receiving support from Harbour complete the support, and we've got 100% staff retention. When we started, everybody that's came to work with Harbour stayed here, so we must be doing something right. And I think one of the things that we do right for the supported people is we try and remove all the barriers. We're offering transport, digital access, and rural isolation. Digital inclusion officer does an absolutely fantastic job. Vary does a fantastic job of reaching people at their needs as well, and offering that digital access, which has been life-changing for some people. It gives them that restart in their journey, and then they can start to access the face-to-face stuff and get themselves back in to the community to access support in the community. And we've got the manageable caseloads as well, which I think is dead important. We can offer really positive outcomes to people. We can offer intensive support. The support that we offer can be 2 and 3 times contact in a week, and if you've got big caseloads, we know that isn't possible. So we try and manage the staff's caseload as much as possible. So I think that's how the Harbour model works. Some of the bullet points of how the Harbour model works so effectively. And I'm going to introduce now Megan, and Megan's our family support officer. She's going to talk, support worker. She's going to talk about the family groups, her experience in the family groups and the family workshop that her and Vicky's developed. So Megan, would you like to tell us a wee bit about your role at Harbour?
Yeah, thanks very much. Hi everybody, I'm Megan Brown and I'm Harbour Ayrshire's family support worker. I came into Harbour just over 2 years ago, volunteering, and I joined the family support group here down in Ayrshire, and I volunteered in there for a couple of years. So I did. Initially, I went into, I believed that I was going into help and I was going into support people because of my own lived experience. I'm the daughter of an alcoholic, and I was brought up in a family that was saturated with drug addiction, and it was lovely because what ended up happening was I realised that I needed family support myself, which I got, even though I'm a recovered addict. I've been in recovery long term, but I actually needed to access family support. So Vicky, who's our volunteer coordinator, she'd created this 8-week workshop through her own lived experience, and she took me through it, and it completely changed things for me. It gave me an awareness that I hadn't had before. So through that, I actually gained part-time employment with Harbour just at the start of the year, and now I'm privileged to be able to deliver that 8-week workshop myself. And the workshop was created about 14 months ago, and in that short period of time, we've been able to take over 90 family members through the workshop. We initially started doing it as part of a group setting, and what we realised was some people needed one-to-one support as well as group support too, which we were able to provide. So basically what happens is if somebody comes into the service that's looking for family support, I initially contact them. I arrange to meet up with them, get a sit down and get a chat with them and see how they are, what's been happening for them, and I just ask them what kind of support it is they're looking for. I encourage them to attend the Harbour family support groups, which is incredible for them. They get to sit in a group setting with other people, and first and foremost they realise that they're not suffering alone. They get to share their experiences with each other and stuff, which is really, really good. And then I'll encourage them to go through the 8-week family programme, the 8-week family workshop. So we do it, there's 8 subjects in this workshop, and they've got the option of doing it as part of a group setting, or they can do it one-to-one if they feel that they're able to get maybe that wee bit more vulnerable and honest, and open up a wee bit more about their truths and their experience. So we do offer that. And one of the first things that we do is the explanation of the disease. Do you know why their loved ones are suffering for this illness, for alcoholism and drug addiction, and the biggest thing we've found through that is they get to realise that it's not their fault. They didn't create it in their loved one, and they certainly can't cure it. So we give them support with that, and as I say, there's another 7 weeks, and we cover things like denial, and we look at codependency, and how these family members don't, you know, their well-being and their happiness isn't dependent on what their loved ones do or not doing, and we look at different options and how we can try and combat that. We bring in awareness around about enabling and helping their loved one, and looking at setting some kind of healthy boundaries and no angry ones. We look at how they can detach for their loved ones, but they can detach with love rather than with anger. And the last week we look at the actual title of the 8-week, the week number 8, Sorry's Tools for Freedom. So it's not a case of just taking these family members through the 8-week workshop and then it's like that's us finished. Hope you got on all right with it. You know, we do offer additional support after that, but the tools for freedom that's in the last week is we get the opportunity to see if these family members are needing any additional support, and that's where we're privileged to have good relationships with other services. Do you know, if they're maybe needing some financial support or legal support, if they're in hardship, emotional support. And again, we always encourage them to continue to go to the family groups and different fellowships and stuff like that too. So after the Day Week workshop, what we've done is we do evaluations. We send the family members out evaluations, and the feedback on them has just been incredible, especially over that short wee period of time. What we get to see is that 92% of the family members that we've worked with can now offer a better level of support for their loved ones, which is high numbers, which is incredible to see. 95% of them that filled out the evaluation during the workshop, they felt safe, they felt protected, they felt as if they could share confidentially, and actually, if every one of the evaluations, 100% of them recognised the absolute importance of looking after themselves and looking after their own well-being. And if anybody's wanting to look at any of that information, Eddie can provide you with it. So, as I said, I did join Harbour on a part-time basis, part-time employment in January, and so far it's gone incredible, the support that we're offering these families, you know, the difference that we're making to them. I always say, you know, the importance of family support is huge, especially in this area. We looked kind of statistically, and with drug addiction and alcoholism, you know, it doesn't just affect the addict and alcoholic. For every one person suffering for the disease of addiction, there's at least 7 people around about them that's affected by it too. So it's really important that we continue to do the work that we're doing and learn and tie in with other services and all work together and stuff, because as we can all recognise, you know, drug addiction doesn't discriminate. It can land in any one of our doors at any point, and we want to continue to support people in active addiction and alcoholism, but Marrows to support all the people around about them that's suffering too. But if anybody's looking for any other information or anything that I've not covered, I can pop up my wee email address, and if I can answer any questions or anything, I will. Thanks very much.
Hi Megan, thank you very much for that. That's great, and you've been absolutely brilliant since you came to work with Harbour. It's been a pleasure to have you with us, and the work you're doing is absolutely phenomenal. And I've seen it firsthand. I've seen family members recreate their lives, and no matter what's happened with their loved ones. And I done an evaluation last year, and 60% of the family members who were receiving the support, their loved ones was in a better place. So the impact isn't just for the family members; it's for the loved ones as well. And it's great results that we're having in there as well. The family groups are some of the best attended groups, between 20 and 25 family members attending the 3 groups we've got in Ayrshire. So great, Megan, well done. So Vicky, I'm just going to bring you in now. If you could maybe speak about the Bridge to Shore project, please.
Yep, thank you, Eddie. So I'm here to speak about the amazing Bridge to Shore project that Harbour Ayrshire have created alongside the Scottish Government toolkit. What I want to start by saying is the Bridge to Shore project is so successful really because of the people. If it wasn't for the amazing volunteers that I've had the opportunity to work alongside, this project wouldn't be able to exist and wouldn't be able to help people to thrive. And it really is the people that come along looking for support and looking for a new way of life and a different way to live. A way where they might get a bit of hope into education, into employment, and just getting so far away from the life they were living that might actually end up supporting really long-term recovery. So I just want to show my gratitude first for every person that has came on the Bridge to Shore project, and for all the wonderful graduates.
So I'm just here to basically talk you through how the project works. So first of all, our recovery practitioners will work with them from taking them from crisis into stability for the first sort of 30 days. If our recovery practitioners see something in them, or if the supported person hints that they are looking to get into some sort of training, education and employment in the future, our recovery practitioners will then speak to them about the Bridge to Shore project. At that point, they'll contact me, and that's when I'll send them the job spec for any current vacancies, volunteer vacancies that we have within Harbour Ayrshire. And then if they're interested, they will be invited in for an interview with myself. Going along with the guidelines of the Scottish Government toolkit, one of the things was sending them the interview questions first, just to make sure that we have a full trauma-informed approach. Some of these people, you know, haven't been in an interview before. Some have been at a long-term, often long-term sick, or, you know, haven't been in employment for a while. So I'll always send them the interview questions, and it's always only myself who conducts the interview, just to help them a wee bit. We took some feedback from the first few, and they preferred it when it was just me in the interview. So making it as comfortable as possible for them. Once they come for the interview, they find out that day if they have secured a position within Harbour Ayrshire. And then following that, the next thing would be is that we arrange their induction, and through that we send them like a Harbour Ayrshire welcome pack, a Bridge to Shore welcome pack, and in that is the volunteers handbook, the welcome letter, the volunteer agreement form, and just full instructions in the induction process, just so they're all informed of what's going to be happening. Then they'll come in for their induction with me. I'll explain the role, the volunteer role that they're going into, whether it's into the groups, the community support vehicle, the helpline team. We'll brief them on that, and then we'll get a wee chance to discuss any convictions that they may have, just so that when we're applying for their PVG, and that's in a nice safe space just with myself. Then we get in our digital inclusion officer, because there's an online training programme at the start of the Bridge to Shore project. We use the NHS TURAS e-learning programme. So we get them in, and our digital inclusion officer can provide them with tablets if they don't have any e-learning equipment. She'll take them through the setting up the email and setting up the tablet, showing them how to work it, and I'll get that learning account set up, and they get 8 weeks to complete the e-learning programme as well. That e-learning programme consists of like trauma training, mental health, adult and child protection, suicide prevention, equality and diversity, just really upskilling them, and they get certificates with each one as they go along, helping to build their confidence and self-esteem. They're then provided with a wealth of face-to-face training, such as the PSST. We link them up to SDF e-learning. They get group facilitator training from me, drug and alcohol intervention training. We get them the assist training. Pretty much everything that's out there training wise, our volunteers are given the opportunity to get engaged with it. When the time comes and ready for getting into education and employment, we start to sit down and build their CV. And that can be looking over all their past experiences, bringing in the lived experience and everything they've done with Harbour Ayrshire so far, between the learning, the certificates they've gained, and all their volunteering experience. It's amazing how the CVs actually turn out. It's brilliant to be part of it. So we go through the CV building, then I start to help them with application forms. When they get an interview, I'll then sit with them and help them with interview prep. I can also get funding for interview clothing as well, just to help them like really feel good going into the interview, and just making them feel that they deserve to be there, that they have a place there. We can also get them driving lessons, which we all know greatly increases their chances of getting a job. And during the course of the Bridge to Shore, they are offered therapy sessions as well, just getting down to the underlying issues, the causes, the conditions, helping to clear up their past, or at least make sense of it. And this again can really promote long-term recovery for them as well. The stats are amazing. So last year we get 53 people into full-time employment and 21 people into full-time education. And 22 of our Bridge to Shore graduates are actually working in the health and social care field. lived experience, but really upskilled people as well. And they are employed in areas such as the NHS, local rehab facilities, the ADPs, We Are With You, a whole range of health and social care things. So yeah, it's just phenomenal. It's an absolute phenomenal thing to be part of. And like I said at the start, it really is the people who make it. When they come to me, they've got all this drive, and it's just incredible to be part of it. I'm a tiny part. The people in the project really are phenomenal. So thank you very much.
Thanks, Vicky. Thanks very much for your presentation, and you're far more than a tiny part of what we do at Harbour. You're a massive part. And do you know, I was told very early doors by my first mentor, he says he was a manager of a project in violence reduction, and he says to me, Eddie, what I've done, he says, I've surrounded myself with people who are really better. They can do things better than I can do, and that's exactly what I've tried to do at Harbour. I've surrounded myself with some amazing individuals, Vicky and Megan being two of them, but we've also got Stacey and Rab and Ian and Amanda, who's in the community as well, which they do amazing work. So one of Vicky's Bristol Shore graduates was, before he came to Harbour, the year before he came to Harbour, it cost the NHS over £60,000. We done a cost analysis for this case study, and it cost the NHS over £60,000, and with his housing benefits and his benefits, it was £20,000. So it was over £80,000 a year he came for Harbour. He came through Vicky's, received one-to-one support at first, and then he came through the Bristol Shore project, get engaged with Vicky, got upskilled and all the stuff that she just explained there. And eventually, after a year, he became an employee with Harbour. So he's not just now a burden in the taxpayer and the taxpayer's purse. He's now a fully contributing member of society, and spending all his money in the community and adding to the community. So an amazing success story, and he's now in the community helping people to, with his own experience, his own lived experience, helping people to come into recovery yourself. So we've got an amazing team running about us. So I'll just go back to sharing the presentation again. Thanks, Vicky, for that.
Thanks, Eddie. Have you got other stuff you want to share in your presentation?
Just if I've got time left,
sure.
Ruth, yeah, just a couple of wee bits. I'm just getting the next slide up there. If you bear with me, I think I'll just let me stop sharing that and bring it back up, Ruth.
Thanks, Eddie, take your time.
I probably should have let you thinking there. I probably should have let you done this, Ruth. Right, so that should have happened there. No, it's not working now. Right, so there we go. So Vicky's done a Bristol Shore bit. So why this matters to Health Improvement Scotland? So it shifts the support that we're offering at the moment for reactive to preventative models. What we're doing at the moment is we're standing at the bottom of cliffs and waiting for people to fall off with some of the models that we're using at the moment, and it's really ineffective and it's very costly as well. And what Harbour's trying to do is do preventative measures like the early interventions. And we've done some work in the schools as well. We just completed a 12-week programme for one of the academies in there as well, with kind of young boys that were disengaging with the schools, and we tried to give a wee bit of awareness of the pitfalls of what can happen when you get involved in substances and stuff like that. So also demonstrates a community-led system improvement. In Ayrshire, we're absolutely inundated with grassroots services. It's doing some fantastic work in their communities. We've got a wee saying when we go into presentations out with Ayrshire, we say the Shire's on fire. It's literally on fire with the work that's happening in our community at the moment. Everybody trying to work together as well. The grassroots service are doing some fantastic work. And what we're doing is also aligns with the whole system's public health approaches. When I came into employment in 2015, I went to work with the Violence Reduction Unit. And in 2005, when they were formed, Glasgow was the World Health Organization that classified Glasgow as a murder capital of Europe, and they formed the Violence Reduction Unit to try and resolve that. And by the time I joined in 2015, they had a public health approach. They'd identified violence as a public health problem, and they got everybody that was involved in violence and supporting violence and it's around the same table, and everybody started working together. And by the time I started in 2015, the murders in Scotland were reduced by 50%. So that whole system's public health approach is absolutely worked brilliant there. And I believe when we do that, they'll reduce the impact and the demand in our acute services. We know now that the services in Scotland are absolutely stretched to their maximum. We're public health services, we're statutory services, we're commission services, and I think if we have a health approach, a whole systems health approach, and we all get starting work together, we can have a huge impact and reduce the impact it's having on our statutory services. And I'll just close with this wee slide. It takes a village to raise a child. Scotland is a tiny place. There is only 5 million people in Scotland, 5.5 million people in Scotland. And I think you said it yourself, Ruth, at the start of this presentation, there's a movement happening at the moment. And I can feel it, you know, and it's driven by our leaders. Like we've got Tracy McFall at the Scottish Recovery Consortium, who's done some fantastic work with Leros. A few weeks ago, we went down to Nottingham. We were invited down to Nottingham to see a charity down there called Double Impact and the work that was happening down there. Graham Muller is the fella's name, who's the CEO down there, and he took us to a building, and it was a recovery hub, it was called. Sorry, it was a wellbeing hub, it was called. And then within that wellbeing hub, it's a different commissioning service to get down there, but it was 2 charities in the NHS that worked together. There's a charity called Framework Double Impact in the NHS, and they all worked together. Every single person, didn't matter what your issue was, when you went to this service, whether it was you're looking for abstinence, whether you're looking for harm reduction, there was criminal justice in there was housing in there, the NHS had psychiatrists in there, and every single person seemed to be working together, and it absolutely took my breath away. So, and I know there's a lot more money down there, and there may be a wee bit further advanced than we are, but I honestly believe that everybody working together and the community working together and all the services working together, we can have a huge impact, just the same as the violence reduction unit reduced that murder rate. I honestly believe that we can reduce the death rate in Scotland if we can all work together. Anyway, thanks for letting us present today. It was a privilege to be here.
Thanks very much, Eddie and Vicky and Megan. I think your presentation, your content speaks for itself, and for me, I absolutely can see where Harbour not only affects you guys as a workforce, but also the multitude and snowball effect that has on people's families and in their communities and all of that. So massive credit to you guys and what you do at Harbour. And as part of the NHS, it's absolutely a privilege to work alongside you and hear some of these amazing stories. And there will be more materials that we'll be putting out into the system to help other parts of Scotland look at their recovery models and how they become more recovery orientated. So our partnership is very much mutual in terms of getting and gaining so much from you guys and learnings and insights. So thank you genuinely very much for your presentations. Thank you so much. We're going to take a short break just now, and I'm going to be cheeky and ask you to come back at 1:45, which is about 7 minutes. So hopefully that's enough time to get a coffee and a cup of tea and then rejoin us. So we'll be back here at 1:45. Thank you so much. Welcome back, everybody. Can you give me a thumbs up if you can hear and see me okay? Brilliant, that's great. Thank you very much. What a great start. The presentations for the first half have been fantastic, and I hope the colleagues at Harbour can get a chance to go down the comments and just see the feedback and maybe answer some of the questions that's been popped in, because there is definitely a lot of love for Harbour, which is fantastic. So welcome back, everybody. Our next speaker is Professor David Best, who some of you may know, and David is going to share his presentation about community recovery capital and inclusive recovery cities. So part of that is about sharing with us and you guys as an audience the role of addiction recovery, mobilising communities and the frameworks for recovery and how recovery can be better integrated into prevention and early intervention. So I'm going to invite David to come in, and David, hopefully you can see and hear me okay, and I can see and hear you. And then we will afterwards bring in David McCartney and Eddie to take over our sort of Q&A session. So David, can you hear me and see me okay?
I can you hear me?
I can indeed, and we can see the presentation. So I'll pass over to you, David. Thank you.
Brilliant. Thank you so much for inviting me, and for everyone in the audience. The sad reality is you have to have a dull academic at some point in events like this, and it's me. So I'm afraid I will be that dull academic. So yeah, I'm. This is early in the morning for me. I'm currently in New Jersey, where I am doing some work on recovery ecosystems with like the equivalent places that are kind of the equivalent of the harbour, which in America are called recovery community organisations. So anyway, yeah. I'm also, I should point out, far too technically inept to manage my own slides. So somebody else is having to do that for me. So yeah, that's me. Next slide, please. Perfect. And I'm afraid this is a shameless, appalling plug for my own book. So I published a book on called The Handbook of Recovery Capital with a friend and colleague, the wonderful Emily Hennessy, who's an associate professor in Harvard Medical School. So we published the Handbook of Recovery Capital, which I'm doing primarily as a shameless plug for my own work, but also partly to say, look, the body of evidence is now strong enough that I'm really pleased we're able to do that and we're able to push forward in that way. So I'm probably going to start by giving you a little bit of overview of the science of recovery. And then I'm going to go from there on to a bit more about measurements and metrics. And then I'll talk about the switch to much more like a public health type model, which I know both Meg and Vicky, well, not both, Meg and Vicky and Eddie all touched on it. And really, I guess my job over what's now about 15 to 20 years of doing recovery related stuff is really to provide the research evidence that kind of shows a lot of what you do already in the recovery world. Because when I started doing this work, and my background originally was as a clinical researcher at the National Addiction Centre, which is a big teaching hospital in South London. When I started doing this work, there was very little evidence around recovery, and that's not the case anymore. So for whoever wants to criticise the recovery agenda, I think one of the things you can't criticise it on is the lack of scientific evidence. Next slide, please. So, but having said that, one of the things that's so important for me to say, and I always do this in talks now, is recovery science, recovery methods, and a recovery philosophy are not simply an extension of treatment. The way it works is fundamentally different and inconsistent with a traditional treatment approach. So the first thing, which is hard for a lot of professionals sometimes to get their head around, is it involves an element of humility that doesn't always appear in treatment services. So the professional, the so-called professional, has to recognize their expert status is to some extent revoked in a recovery model, because in a recovery model, it's much more akin to a partnership approach. The second part of this is there's a switch from a deficit way of thinking to a strengths-based way of thinking. And that's really important because in a traditional model, and when you use traditional measurement, the assumption is that people have a whole series of deficits, housing problems, crime problems, drug problems, and so on and so on and so on. And the aim of treatment is to get rid of all those problems. And the assumption is if someone gets to some kind of homeostatic zero, i.e. no more problems, that's done. But that's not a recovery model. A recovery model is about building sustainable strengths over time. The definitions of recovery typically talk about things like citizenship, active participation, meaning, and so on. But they are not simply the elimination of deficits. They are much, much more than that. And where do those growth of strengths happen? Well, they don't happen in specialist clinics. This isn't by any means a criticism of what treatment does. And for many people, it's necessary. But for long-term recovery, it's almost certainly not sufficient. That's going to require a much more long-term move towards growth, well-being, what some people refer to grandiosely as eudaimonia, developing a sense of meaning and purpose in life. And it's also really important to say recovery is intrinsically a social process, a socially embedded process. And Megan mentioned in her presentation that the importance of the family. Well, that is one of the layers by which you would judge a recovery model. Don't just look at, does the individual show changes? It's much more about group and societal changes. And then, crucially, by far the most important point I'm going to make about the science of recovery is the primary carrier of recovery is the peer. What is the primary mechanism of transmission of recovery? It's peer-to-peer. I want what you've got, and I'll do what you do to have what you have. In other words, the visibility and accessibility of a successful icon of recovery is intrinsic to the process. It may be that comes from a professional, but much less likely. And so, effectively, if this was a play, the professional goes from being a lead actor to part of the support cast. Peer support services become the key elements of the cast in a recovery process. Now, the other thing, which for me is a worry, and if we compare Scotland and England, and Eddie said some very nice things about England and double impact and Cathy Sobar in Nottingham, but it's not without its problems. And each area has to find its own solutions. And it's really, really important to say what works in Ayr or the Harbour, you can't McDonaldize. You couldn't simply copy that and plant that in Edinburgh, Glasgow, or my delightful hometown of Motherwell. You would have to find a way of adapting and basing it on what the resources, strengths, and assets are in that particular part of the world to make that work. Next slide, please. Now, I want to place this in context. I'm going to come back to this slide. This slide, I'm afraid, is a well-worn slide. I stole it from John Kelly from the Recovery Research Institute, but it turns out he stole it from Mike Dennis from the Chestnut Health Systems and the Lighthouse Institute. But the key point is, typically, the onset age, this is about substance careers. So the average length of a substance career that ends up with addictive behaviours is 28 years. There is about 7 or 8 years off the left-hand side, so the average age of onset typically is 10, 11, 12 for any form of psychoactive substance use. People first start experiencing symptomatology in the late teens towards 20. But then people have 4 to 5 years of attempting to sort the problems out themselves. And then typically they'll have 8 years in and out of treatment services and 4 to 5 long episodes of care. And what that typically means is the onset age for remission or the start of the recovery journey is in the late 30s. And then 2 other statistics we'll talk a bit more about is we talk about a recovery journey as being 5 years post-acute treatment for reasons I'll come on to in a second. And the majority of people make it. In spite of that length of career, most people come out the other end of it. Next slide, please. And what gets people out the other end? So there's 2 ways of framing basically the same thing. The evidence is really, really clear. What do you need to successfully recover? Jobs, friends, and houses, or somewhere to live, someone to love, and something to do. The science of recovery can generally be reduced to those golden threads. I've recently done some work with the Phoenix, who are a recovery exercise organization in the United States, and they have something before the somewhere to live, which is psychological safety. So they would add that as an additional element onto those 3, but basically those are the 3 things. Why is it regarded as a 5-year journey? Well, in the first year of people's recovery journey, the likelihood of relapse is 50 to 70%. And if they make it to 5 years of continuous sobriety, the likelihood of relapse is 14%. Plateaus there and doesn't go any lower. So when we did our European, our Orientated study, our European Recovery Pathways study, we found that in our study, for people in early recovery first year, just over 1/3 of them relapsed in our first year of study. In sustained recovery, if they were recruited in sustained recovery, 17.6% relapsed. For people who at the start of the study had 5 years more of recovery time, the relapse rate was 1.5% per year. In other words, 1 in 66 people relapsed. So nobody's safe, but it's pretty strong evidence. If you make it to 5 years, you're doing well. In the previous slide, it said 60%, but the summary of the evidence published by SAM, so the Substance Abuse and Mental Health Services Administration, they go for a slightly more summary of evidence suggesting that 58% of all the people with a lifetime substance use disorder eventually achieve that 5 years of stable, consistent recovery. Okay, next slide, please. So I'm going to go back to, funnily enough, to work I did most of in Glasgow. It was a study of between Glasgow and Birmingham. This was really the second major recovery study I did, which we published in 2011, as you can see. And we call this the Goya study for a reason that I will explain later, but many of you will have heard me talk about before. What predicts who does well in recovery? Firstly, the more time you spend with other people in recovery. Secondly, how much time of that time you use to engage in meaningful activities, childcare, community group involvement, volunteering, education, training, or employment. The more of that you do, the better you do. Why Goya? Well, Goya is a complex statistical term that stands for get off your arse. The more you do, the better you do. And we actually replicated this in Florida in a follow-up study that was conducted in 2015-16, I think. Where we looked this time, instead of recruited population for a research study, we studied residents in one of 8 recovery houses in Florida. And what we found was that people who live in recovery houses and are surrounded by other people in recovery, they reduce all their deficits and barriers to recovery. But if they also engage in positive, pro-social, meaningful activity, they build strengths. They build personal strengths and they build social strengths. And that was really, really important. 2 studies, 4,500 miles apart, similar effect, but the effect is primarily a social effect that creates the conditions to allow people to engage in meaningful activities. Next slide, please. And what works in recovery services? So look, and I'm not going to go on about this too much. Like most academics, I've never had an original thought in my life. I shamelessly steal other people's ideas and pass them off as my own. And one of my favourites for stealing and passing off my own is something from the mental health recovery field, which was published in 2011 by Mary Leamy and colleagues from the Institute of Psychiatry, where they reviewed a number of studies about effective mental health recovery, and they identified 5 core elements of what does a service have to do to support meaningful recovery. Number 1, create genuine, meaningful human connection. Not behind a plexiglass screen, not on a telephone, not an online assessment. Genuine, meaningful human connection generates the hope and belief that change is possible. And that in turn creates a virtuous circle. Now, CHIME is a wonderful acronym, but if it was actually in the right chronological order, it'd be CHIMI, but CHIMI doesn't sound as good. Positive social connection generates the hope and belief that change is possible, which is the fuel that gets people off their arse to engage in meaningful activity. And the meaningful activity generates a positive sense of identity and a sense of human empowerment. The social part is hugely important to me. And one of the things that I think is fundamental to this is taken from work of an American sociologist called Robert Putnam, called Bull and Alone, where he was kind of interested in the death of group activities in America. And he talked about 3 different kinds of connection or social capital. Bonding, which is the strength of connection within a group. Bridging, which is within the same broad hierarchy of reaching people at different levels, and linking is external connection to communities. And I'll come back to that in a bit. Next slide, please. Right. And the social capital theory really gave rise to the quantification of recovery in the form of recovery capital. And recovery capital has effectively been a huge blessing to our field, because when I started doing recovery work in 2008, 2009 kind of time, broadly, it was derided as a concept. Recovery science was derided as a concept because it was all about spirituality and God and meaning and purpose and blah, blah, blah. And nobody took it seriously. But two American academics called Bob Granfield and William Cloud wrote a fabulous book called Coming Clean. And in that book, they started drawing on something which they eventually termed recovery capital to refer to the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from alcohol and drug problems. And crucially, the same year, William White, the kind of guru of academic recovery research, and William Cloud basically concluded that stable recovery is actually much better predicted on the basis of assets, not on the basis of pathologies or deficits. So that's quite an important thing. All right, next slide, please. And this really has motivated and driven much of my work. But the other academic I really want to kind of give credit to and kudos to is my own academic mentor, who's a man called John Braithwaite, who was the director and founder of the School of Regulation and Global Governance at the Australian National University, whose 2022 book, Macrocriminology and Freedom, contains this wonderful quote: social capital, human capital, recovery capital, and restorative capital are unlike financial capital in that they are not depleted through use. When you spend your money from the bank, you deplete your capital. When you trust someone, you do not deplete trust. Trust tends to be reciprocated, and this engenders virtuous circles of trust building. A politics of hope is likewise redemptive as we face adversity as infectious. We don't call it infectious, we call it contagious. Recovery is a social contagion, if you like, a ripple effect that emanates out from individuals or more likely from groups to impact on families, communities, and the wider society. And more of that anon. Next slide, please. Right, so going back to 2010, I combined our data from Glasgow and Birmingham with data that a slightly scary American researcher called Alexandra Lodi had gathered in New York from 356 people in recovery. And we combined our data to say, all right, if we want to start thinking about recovery as something that we can count, how do we come up with an operationalization or a system for it? And we came up with this threefold category, which we still to some extent used, although we've relabeled one of the terms. So over that 5 years, the slice of the pie that effectively is about making recovery self-sustaining over time is called personal capital, which basically is things like self-esteem, self-efficacy, coping skills, resilience skills, communication skills. But to mix my metaphors appallingly, it is the scaffolding around that slice of pie, the social and community capital, that allows it to grow and build and develop into a self-sustaining slice of pie. Now, I have no idea what a self-sustaining slice of pie is, so I'll move on to the next slice. Next slide, not the next slice. Oops. Right, okay, so this is your homework. I'm not going to leave this slide up for long. Next slide, please. But I want everybody to memorize this slide because I'll be asking questions on it later. The reason I put that last slide up is I'll not be asking questions on it later is to say that is the first 12, I think, of now about 15 papers on recovery capital that we have published alone. This is no longer an area of emerging science. There is now a huge body of research, and we were able to show continuity of care. So in this study, this was done in a wonderful therapeutic community in a jail called Chesterfield County Jail in Virginia, in America. And what's amazing about this is there's a TC in the jail, therapeutic community in the jail. People go into the therapeutic community, and when they complete that program, they're released into one of 3 recovery residences in Richmond, Virginia. And then they go back at least once a week to continue the program in the jail. The recovery residences provide minibuses to take them back into jail to create that continuity and flow. And we were able to demonstrate that recovery capital is not only sustained over that transition, but grows. Next slide, please. We were also able to show in recovery residences that effectively, as you add more intensive supports to people. So what we did in this study was in a group of recovery residences in Virginia, we identified that there were a group of people at massive risk of dropping out early, typically people with very low levels of baseline recovery capital. So when they were assessed at intake, those with low levels of baseline capital were afforded concessions on their rent. They were afforded extra. They were provided transport to justice appointments, transport to mutual aid groups. And what we were able to show was with intensive support, you can actually build recovery capital over time in an intentional, planned and strategic way. And within 6 months, they had largely caught up. It wasn't one of those things where you say, they're just not doing well and they fail. So recovery capital is both a metric, but being a strength-based metric, you can also use it to kind of develop. Next slide, please. The other thing that I keep thinking, should I include it in the first slide, is I tend to think of a fundamental philosophical difference from treatment to recovery is that we tend to assume with treatment that the change process is kind of inside out. You change what goes on in the body with medication, you change what goes on in the head with kind of therapy and counselling. But as in the last study, a recovery model, particularly for those with low baseline levels, is much more of an outside-in model. In other words, you assume that people who have low levels of capital at the start need to be assertively linked to positive recovery role models and to meaningful activities and positive connections that support that recovery journey. And so we think of this as a kind of outside-in model. And it would also suggest that you should not think of recovery simply as a form of aftercare. And I'll come back to this right at the end. Recovery should be thought of much more as a form of prevention and early intervention. Next slide, please. So, in fact, the other thing that recovery capital does is it gives us a kind of formula. So for any given person, we can calculate their likelihood of recovery as a combination of two factors. One, the measurable recovery a person has, but that can only become expressed if the conditions exist in the community they live in that allow recovery to flourish. And that applies on both a meso, middle, and a macro level. So in other words, if you're in the Harbour project, people with low capital will have the potential to flourish only if that effectively maps their strengths, capabilities, and skills and links them to other people, other groups, and activities that are almost like epigenetics that allows those things to flourish. I do a lot of work in English prisons, and one of the questions we ask there is, how can we possibly increase the opportunities to allow people to start meaningfully growing and sustaining recovery capital in prisons that are awash with spice, ketamine, and all kinds of other things? How can you possibly create sustainable conditions for recovery? Next slide, please. And our work isn't my work. Yeah, I just can't stop tinkering with stuff. And one of the other things I'm actually doing here in New Jersey is we've developed a new scale, which is the appalling acronym of PLARBS, which is the Peer Wellbeing and Recovery Building Scale, because it is really important to say, while we think of 5 years as the journey of recovery for people not to relapse, it's a constant ongoing process of growth. And we've developed a scale which is effectively a measurement of the well-being of the peer workforce, and it consists of 3 things: the individual's own recovery capital, their perceived ability at helping other people to grow their recovery capital and their organisational fit and functioning. So the original phase of this work we piloted in Auckland in New Zealand with an organisation called Odyssey, with Recovery Connections in Middlesbrough, and with Recovery Core in Minnesota here in the United States. And for this work, I get support from the Archway Institute in Missouri, as well as the project here. Next slide, please. And what our data show, and none of you should be surprised about this, is there is a bind of three things that the worker's own recovery well-being and recovery capital is strongly linked to their perceived ability to help other people build recovery capital. In other words, if you're burnt out, miserable and stressed, you're not going to help anyone else recover. But crucially, both of those things are tied to how much trust and satisfaction you have within the team. Now, where we work with recovery, lived experience recovery organisations, that's great. But where there's a peer worker who is embedded in a larger treatment service or treatment team, much less so, because they are much less likely to experience that sense of trust and satisfaction of where they are. We've also just finished a second phase of work in Middlesbrough. We've linked this to stigma, and we've just submitted that for journal publication. And that's a big part of the work, is around saying, we cannot ignore recovery champions. And I was responsible, I think, in the 2010 English drug strategy for getting the term recovery champions in there. But now it's that's become kind of neglected, because your peer recovery workforce, paid or unpaid, are the carriers of the social contagion of recovery. And it's crucial we both map, measure and protect them as they move through their own journey, because as they become burnt out or distressed, they become less effective carriers of recovery. Next slide, please. Yeah, and when you look at the organisational functioning of the peer workforce, and this uses a measure called the ORC, the Organisational Readiness for Change, you'll see that typically peer workers and professional workers are broadly similar, apart from two things. One, there's a much higher level, a significantly higher level of social cohesion among the peer workforce, and there's a statistically significantly lower level of stress and burnout among the peer workforce. Next slide, please. And for me, essentially what I'm doing here is to say, how can you link four component parts to map and measure and grow recovery capital? So working with recovery organisations here, we're creating an organisational measure, which is a much nicer acronym of ORCA for the Organisational Recovery Capital Assessment. The PWARBs for workers and our RECCAP for the individual, but we also have a measure of family recovery capital, which we're including in this. And this is the idea to create a much more kind of holistic and socially embedded model of recovery and recovery capital. Next slide, please. I am nearly finished. You'll be pleased to hear. Because it's so important, and this is a wonderful slide. God knows what it means. I certainly don't. But this is called the socio-ecological model that's developed by two academics, J. Lee Tucker and Katie Vitkovits, who have effectively described how the layers of impact, kind of as I mentioned earlier about outside in, there are layers of societal, regional, social and individual factors which play down an impact on recovery. But it's really important to understand they are bi-directional. And the last thing I'm going to briefly touch on is how we try and translate that into a model for action. Next slide, please. Yeah, this is a very, very old slide from the Glasgow Recovery Walk, which I think was 2010 or 11 or sometime around about, maybe a bit later, maybe 2012. Anyway, the whole point of this is, why have public-facing events for recovery? Well, I'm going to go back to the Putnam stuff about social capital. You have it to celebrate recovery, hugely important. But you also have it for reasons linked to different kinds of social capital. The first thing you're trying to do with this kind of public-facing event is to increase the bonding within the recovery community. Crucially, you also want to bridge. This was Glasgow Green, and you want to be able to show to people still struggling with addiction, family members who are confused and not sure what to do. We want to show them recovery is accessible, attractive, and viable. And effectively, making it visible is a core part of that process, and that's bridging social capital. And the last part is to have people of the general public come up to you and say, what's this all about? What's going on here? And that's linking social capital. So effectively, as we start to think about recovery carriers and recovery champions and recovery advocates, we think of their impact in different domains. Oops, Ruth has appeared on the screen, so I guess this means I'm running out of time, so I'll go fast for the last 2 minutes. Okay, next slide, please. And that brings me to where I want to conclude, which is the Inclusive Recovery Cities model. This is something we launched formally in Middlesbrough in 2023 at the Riverside Stadium, and it has grown hugely. And by Recovery Month this year, we will have more than 25 inclusive recovery cities in England, and we will have more than 50 globally. And I'm pleased to say our most recent global edition, which we're currently working towards, is Bulawayo in Zimbabwe, which is going to be our latest inclusion, which is very exciting. However, on the 20th of March, we will also launch our first Scottish inclusive recovery city in Dundee, and far too late. But nonetheless, it's a very good thing. So that's going to happen in Dundee in the 20th of March. But the whole idea about this is, how do you make recovery accessible, visible, and attractive to make it socially focused and mediated? Next slide, please. And I think this is nearly the last one. Loads in England. You can see how bad if you'd never get a job as a geographer. Next slide, please. That was our original cohort of 10. Why is this important? Why this is important is because the fundamental shift of a recovery model is it switches from being aftercare. The whole goal is to increase active participation and citizenship. So recovery switches from an individual model of aftercare healthcare to a public health model of community engagement, focus, and change, so that it has a role in diversion, primary prevention, and targeted prevention as well. Next slide. I think that might be done. No. So the whole point is, within that model, going back to this slide, we no longer are only thinking of recovery services at that last point of continuing help and mutual aid after that painful journey. If you can make recovery visible, accessible, and attractive, our ultimate aim is to get the 60% higher, but significantly reduce that 4 to 5 years and 8 years at the start of the journey. Done. Thank you very much.
Brilliant, David. Thank you very much. And if we could bottle your energy, we would be millionaires. So thank you so much for your presentation. And I really love the idea.
When we're done, I'm going back to my bed.
Not just yet. Hang on for another 30 minutes. I love the idea of Dundee being able to be the first Scottish inclusive recovery city, and I would absolutely encourage colleagues across Scotland to consider if that's something that they could champion for, and certainly within Health Improvement Scotland it's something that we'd be really interested in as we plan for and prepare for our programmes after the mission. So thank you so much, David, joining us all the way from America. So I do appreciate you being up at 5:30 this morning to support us in this presentation. I'm now going to ask David McCartney to come on screen, and Eddie, and I'm going to pass over to you, David, to facilitate a conversation about recovery with our speakers. And please, colleagues, please use the chat as we go along, and we can pick up any specific questions that you've got. And David McCartney, can you hear and see me okay?
I can, Ruth, yes.
I'll pass over to you. Thank you.
Thank you. First thing to say is thanks very much to all of the Harbour guys and to David. I don't know about recovery being contagious, but enthusiasm and inspiration feels a bit contagious. I feel my energy levels are higher now than when the session started. What we're going to do in the next little bit of time is just tease out some of the things we've heard with a bit of conversation. And I suppose, going back to what you said and your colleagues, Eddie, at the beginning, the success and impact of Harbour seems to be related to the people. We heard that 2 or 3 times, the people that are involved. But also at the heart of that is that these people are people who identify as being in recovery. So a question to maybe to kick things off to both of you is what does it mean to be in recovery? It means different things to different people. And for you, David, when you come to, I'll ask Eddie to start, but for you, David, what does it mean what does the research tell us about why that's important and what the impact of it is? So Eddie, first of all, I guess kind of lived experience, what does it mean to be in recovery or to identify as being in recovery?
Well, I suppose, David, anyone who identifies themselves as being in recovery, as far as I'm concerned, are in recovery. It's not for me to tell anyone what they can and cannot identify as. My recovery, the model recovery that I chose, or possibly that chose me at the time when I was ready to throw the towel in, was a absence-based recovery. And that's the model that we brought to Harbour. Through my own lived experience of coming through absence-based recovery, and it's not even about abstinence. I don't believe being in recovery. It's not just about not using substances, because there's been times through my journey where I just wasn't using, and trust me, I didn't feel as if I was in recovery. So when I came in the model that I chose, it allowed me to understand really what addiction was, and because if you're not going to seek a solution to a problem you don't know you've got, I had to really understand what addiction was and the causes of addiction and things like that, and then I had to start to deal with that properly. I had to look at the stuff in my past where the issues that I started using substances to alleviate, and when I done that, I learned some healthier coping strategies. So all my life I carried about stuff. A, I was responsible for things that I was nothing to do with me, and B, the stuff that had been caused through my journey, through the people at the time. We had to learn to accept that and take responsibility for the stuff that I had done, make amends for that, and learn some healthier coping strategies in my life. And what happened to that when I went through that process, I got lit up. And when you're lit up, David mentioned it a minute ago, when you're lit up, you kind of want to help other people with this stuff. So for me, that is how I classify myself in recovery. But the answer to your question is, if you say you're in recovery, you're in recovery, as far as I'm concerned.
Thanks, Eddie. And David, anything to add to that from what does the research tell us, or what's the impact of it?
David, I've always got things to add. So, I mean, the first thing that I think is worth saying about this is, that has been the view. Eddie's starting point there. Phil Valentine, 2011, basically said, you're in recovery if you say you are. And that doesn't seem a terrible starting point. Not very helpful from a research science point of view. And what we've tended to, all the definitions have typically contained three component parts. So they typically talk about something to do with abstinence or control over substance use. And I think a lot of that now is about avoiding intoxication. So a lot of the discussion is about, so that allows for both medicated use and controlled use. And you get these complicated questions. If you get obsessed about this, you get into these complicated questions about if somebody was a heroin addict and they have a glass of wine 5 years later, are they no longer in recovery? Well, I'm with Eddie and Carl. It's not my place to say whether they are or not. So definitions typically involve three elements: something about sobriety or abstinence, something about global health and well-being, and something about citizenship and active participation in the community. And in the UK, that's probably been the most contentious of the three elements, is that does it necessarily involve something around the giving back component? I'd also want to say, because, I think wrong-headedly, John Kelly and Ed in the United States and Ed Day in the UK have tried to measure the prevalence of recovery. And that seems to me, for that reason of it's self-defining, I don't think you can measure it by doing questionnaires and surveys, because it seems to me there's also three levels of kind of being in recovery. Do you see yourself as being in recovery? So, which is a separate question for, are you going to talk to other people about that? The second thing is, for a lot of people, they talk about a sense of belonging to a group or a tribe or whatever that defines their recovery as partly about social identity and social belonging. And the third element, I think, is, do you want to be part of club recovery? In other words, are you going to put on the T-shirt, the sweatshirt, and go out and take part in recovery walks here, there, or everywhere, And one of the things, I had a PhD student called Beth Collinson who basically said men are much, much more likely to be members of club recovery than women are. So men are much more likely to want to join the recovery fishing club. Women are much more likely to want to join the air fishing club. And I think one of the things that's so important that we understand too little about is vast majority of what we know about recovery comes from white, male, working class, 40 to 60-year-old drinkers and heroin addicts. And, you know, we know much, much less about other cultures, other groups, and other substances. So we need to have a caveat around that. David, I've finally finished.
Thanks, David. Thanks to both of you for those answers. Given that the evidence says that recovery is a social phenomenon that happens in communities, and not primarily, although treatment can be part of it, which is a challenging thing as a treatment professional to hear. You said that you call this so-called professionals. I'm sure that was meant lovingly, but the idea that we're part of something much bigger. I think most of us can get our heads around that. But when we look at what little evidence we have in Scotland about how well we connect people from our treatment facilities to the recovery organisations like LEROs, lived experience recovery organisations, and mutual aid groups, it's appalling. The two ADP needs assessments that have been done in the past showed very low levels of connection, less than 2.5%. So how do we connect people in an effective way up to those community recovery resources so that we accelerate or catalyse community recovery? Eddie, I'm going to ask you first, just because you're kind of doing that in a practical sense. How do you connect people up to community recovery resources outside of Harbour itself?
Yep. So Gabor Mate says that the opposite addiction is connectedness, and we believe at Harbour this is all about relationships. Not just relationships with the people that we're supporting, but it's also relationships with the services that we're working in partnership with as well. Harbour couldn't have, we're only a 3.5-year-old service. Harbour could never have done what we've done if it wasn't for the support of the people that were partner organisations. But how we support people into that, when we're doing handovers, we do soft handovers, so the staff will take people to appointments for their services, because we know, David, that drugs and alcohol is a symptom of what we suffer from. So what we try to do at Harbour is to support the underlying issues that's causing the substance use in the first place. So we try and take them to soft handovers and remove any barriers, give them as much support to remove any barriers as we possibly can to get them into recovery. You mentioned that there, the stats that's coming for rehab. When our body service, a big challenge is to get people to rehab. And what our focus there is removing any barriers. And if we can't remove the barriers totally, what we do is try and support the person to overcome those barriers. Also, we're looking at making our recovery as visible as possible. We need to let people know that there's support in the local areas and get the word out there. There's help there if you need it. So we're massive on our social media and stuff like that as well. So really, we're just connecting with it. But lived experience, that's probably the biggest tool that we've got, is our lived experience of letting people know that recovery is possible.
Thanks, Eddie. And David?
Firstly, I'm not happy to try to get me into trouble for my so-called professionals comment. What I really meant by that in part was, because it implies that peer workers aren't professionals. It implies they're kind of amateurish in a way that I think is misleading. And the other ... I'm also well aware of the fact of the level of stress burnout that so many professionals face now because of caseload sizes and some of the demands that are placed on them. So then the second thing I want to say is I'm involved in a project with HMPPS, the prison service in England, which is, to me, just such a nicely innovative thing. So in HMP Birmingham have now partnered up with 2 lived experience recovery organisations, Soot in Wolverhampton and Datus in Birmingham, so that they can come into the prison, engage people pre-release, and then have continuity of care post-release. We're doing exactly the same in a pilot with Recovery Connections in the northeast of England with HMP Kirklevington and HMP Home House. And this stuff is well overdue. Because of the churn of people in the prison service, getting that stable, visible recovery community in the prison is really hard in England just now. So effective partnerships and assertive linkage with lived experience recovery organisations is important. The other thing, which I know you know, David, but I just want to take this chance to put on record, is that the evidence base around 12-step mutual aid is overwhelming now. It is huge. So let's start with 12-step. Even if you go for the very strict medical stuff, you know that there's now randomized control trials that show the effectiveness of 12-step. There is a Cochrane review, which is very clearly indicates it. And you know, one of the greatest studies, going back to what Eddie said by Mark Litt and his colleagues in 2007, the randomized trial of people coming out of detox. If you could add one clean and sober person to their social network, which was typically somebody from AA, you increase the chance of abstinence in the next year by 27%. If you are determinedly against 12-step for whatever reason, then the recent PAL studies, peer alternative studies by Sarah Zamori, which talk about second wave mutual aid organisations like Women for Sobriety and Smart Recovery, show equal effectiveness. But the key is peer-based, community-delivered interventions, and it should be the job of every professional to get their caseload, particularly if they're overworked, out to what John Kelly has described as the closest thing to a free lunch in public health.
David, you mentioned assertive referral. What is that? What's the technique of getting people along to mutual aid of any variety?
Nail leaflets. Don't just tell people what's going on. You have to get people through the door of whatever service, you know, and the best person to do that is a peer advocate and champion who's ready to go in there. So we've got in Newcastle, we've got a Recovery Connectors project where we've recruited a dozen wonderful folk on their own recovery journeys, and their job is effectively to do exactly that. They are they're getting accredited training at the moment. They will then be, their job will be identifying what people's skills, passions and interests are and assertively linking, i.e. talk to them about whatever they're going to do beforehand, take them there the first time, introduce them to people, talk to them afterwards about what's happened, support their engagement, drive them there or get a minibus to get them there. Make sure people are practically supported about geography, childcare, whatever it is, to get them in the door.
Okay, thanks, David. I've got a specific question that came from the chat, Eddie, for you, and it relates to supporting families where someone has lost a family member. Is that something that Harbour does, and how do you do that?
Yeah, that's difficult, David. We have got people, we have got family members who have lost loved ones who come to the family support groups, but must, and listen, I'm only speaking from an opinion here, it must be really challenging for them, because what we're trying to do is we're trying to create hope in the family groups that that recovery is possible for the loved one, but B, that even if the loved one doesn't access support at that time for whatever reason, then we can support the family member. But what we try to do is we access some funding for family members who have experienced bereavement, and we'll link them into some therapy and try and get them a bit of therapy and even just the peer support and going for coffees and talking to other family members. And a couple of them have really used that horrific experience that they've had by losing a loved one, and to try and help the family members who are still in the midst of it. One guy, for instance, came. He lost two sons, two twins, 10 years apart. Devastating for his family. He'd split his family up. He was ready for losing his job. He had just shut down when the second boy passed away. He just shut down, and the daughter actually came to the family groups, and the mother followed the daughter into the family groups, and the two of them done really well. And the father, who was estranged from the family at that time, the daughter kept saying to him, come to the family group, come to the family group, you just don't know. And the fella came to the family group and just started to absolutely thrive in the family group. And so much so that he absolutely recreated his life. He got an invite to go to to New Zealand for his sister's birthday, and he says it's something I wouldn't even have thought about before I came to Harbour. But he went to a surprise birthday party for his sister. He actually met a woman when he was at the party, fell in love with her, and he's now moved to New Zealand and he stays on a farm. So sometimes it just works out, David. But the reality is it must be really challenging for people even to come to your family groups. But get them a bit of therapy and a bit of understanding, and just with the hope at times a great healer. You'll never repair a broken heart, but at least we can help them mend it a wee bit.
Thanks, Eddie. That's really touching, a good story about that connectivity that makes the difference. David, a specific question for you. You mentioned in one of your slides, I can't remember if it was a scale or some sort of measurement or assessment of how recovery-oriented a service is. Can you say a little bit more about that? How would a service know how recovery-oriented it is?
Well, effectively, what we've done with this is we've taken what we know are the effective elements of recovery community organisations, and we've turned them into a scale. We piloted it in Michigan a couple of years ago, and we're now going to be doing it here in New Jersey. And the idea is basically we just do what we've always done. We take the evidence base, we create a measure from it, and we turn it into something scalable, and then we'll test it. It's one of the things that I think has been massively missing in the recovery field, has been that sense of how do we create confidence by having minimum quality standards in what we do. And that's partly what the College of Lived Experience Recovery Organisations has tried to do. But I think there's also a sense which, well, I have been such a kind of happy voyeur of recovery communities for the last 15 years. The incredibly dull, anal job I do is to write the questionnaires and measures that count stuff that kind of follows on behind, because it's frustrating working with recovery organisations because they all do, or many of them do, incredible things, but nobody ever counts anything, nobody ever writes it down, and generally, we don't know what works because nobody measures it other than getting testimonials from people. Nothing wrong with testimonials from people, but essentially, so what we're trying to do here is build on existing science and develop a measure that says, how recovery oriented are you? And there's things that are obvious, how effectively do you integrate mutual aid groups into your process? How much supervision do the staff get? How much training do the staff get? What's the ratio of clients to each worker? But there are other things that are less obvious, but there's an evidence base around them. So effective, and the whole point of this is, as with the recovery capital measures, they're not meant to be judgments. There's meant to be things that you measure that allows you to say, and what do we do now? I mean, with the peer worker scale in Archway, the whole point of that is we're embedding that in appraisals so that we'll measure the peer worker and then say, right, how do we do a development plan for the next year to help you grow as a peer worker over time? That's another area where people generally just haven't had any kind of systematic model. What do you fancy? I'll go and do a bit of training in this. Well, we want to move away to that, to something that's much more specialist.
Okay, thank you. Another question from the chat. So I'm just trying, there's so many questions, I'm just trying to pick one that's relevant to both. So there's one about the needs of young people, so sort of 14 to 26, 25-year-olds. The person that's posted this has said that we've got these young people hidden in plain sight with emergent drug use challenges and very limited, if any, treatment options. First of all, Eddie, is that something that Harbour's come across, young people, different drugs maybe, or different needs presenting to your service, and how do you meet their needs?
Yep, absolutely, David. The Harbour is the young people that's coming through the doors at Harbour now is absolutely taken off. I think, and it's a new emerging drug trend that's causing the issues. People are coming into recovery now at 21 years of age, 18, 19, 20, 21 years of age. We're absolutely traumatised with the lifestyle, the substances you're using. It's a real impact on mental health. They're coming in experiencing psychosis, long-term psychosis at 21 years of age. So real issues for them staying in recovery. But as David says here, Harbour, we've got a really strong recovery, 12-step recovery in Ayrshire, and we use that to the best of our ability. That's probably one of the most successful things that we've done, actually. So we're referring the young people onto the 12-step fellowships. That's real beneficial to Harbour. We've had three, over the last 3 years, we've had 3 trainee addiction workers for the Scottish Drugs Forum who've came and done a placement with Harbour, 3 young people that they were experiencing the difficulties that I mentioned, and they're absolutely thriving. The 3 of them's doing full-time employment. One of them just graduated there last week. He's now into full-time employment. He passed the driving test while he was with Harbour. He's probably a year and a half clean or something like that. So probably the best thing that we can do for them, because Harbour can only offer, when you're experiencing that level of trauma and you've been in that crisis, it's really hard to have an impact when you're seeing somebody once a week. So we find that referring them on to get building up that recovery capital, and it's young people supporting young people as well now, which we're finding really beneficial, and getting them referred on to the fellowships.
Okay, thanks, Eddie. And David, I suppose from a more kind of academic perspective, is there evidence that the recovery, all the sort of tools of recovery, the concept of recovery capital, the contagious nature of recovery, is all just as applicable to young people?
Firstly, at the age of 92, I don't really feel entirely equipped to talk about young people. So, and having a 17-year-old son, he would definitely say that I know nothing about young people. No, there are differences. I mean, I think one of the things that Eddie touched on, which is so important, is I'd want to signpost people to a lived experience recovery organisation in Bradford called the Create Strengths Group, who have moved away from the traditional focus on alcohol and heroin, and their primary focus is nitrous oxide, ketamine, spice, and other forms of cannabis. You know, and so they're starting to develop an evidence base about what recovery pathways look like for young people, and I think that's so important. The other thing, the other person who does work in this area is my friend and colleague Emily Hennessy has developed a lot of work around adolescent recovery. And you'll not be surprised to hear a big part of that work is about social networks and social identity, but that sense of groups and group belonging that's crucial for young people. In America, you do have recovery high schools and collegiate recovery programs that are much more prominent, are well worth mentioning because there is a big evidence base around the effectiveness of them. There are the same issues applies with any family service, which Eddie also alluded to, is the challenges that the family will typically experience a recovery journey that's asynchronous from the individual's recovery journey. So you have that problem of mismatches of breakdown of radius of trust. As the family's recovery, it doesn't happen at the same time in the same direction as the individual's recovery. And it can take a lot of time. And where I think people who recover through the 12 steps do well in family terms is that whole sense of gratitude, making amends, and open and honesty with your family moving forward is a big thing about rebuilding connection.
Okay, that's useful. Maybe another question from the audience. One of the people who's here posted, how do you address the barriers placed by services mandating people to attend fellowships prior to access services? So I think I know where this has maybe come from, and that source is problematic in my view. But anyway, if a service says you've got to attend one of the 12-step groups before you can access our service, is that acceptable?
Not from my point of view, no. Oh, sorry, Eddie, on you go.
Go on, David, go on.
All right, all I was going to say was, look, you know, lots of people will benefit. We know the evidence base is clear. We also know loads of people benefit from physical exercise. And you wouldn't say to people, I'm going to mandate you to go to badminton classes for the next 2 years, regardless of your choice, preference, and where you are. The whole idea about recovery is there should be multiple activities that tackle multiple domains of recovery. There's no point, when we did our randomized trial of assertively linking people to 12-step groups at the Maudsley, people who English did much better. This is a study led by Victoria Manning. But we alienated a huge number of people by getting them to 12-step meetings when they didn't want to go and they weren't ready and they weren't happy. I don't think you can mandate people to anything. I mean, I think the idea there would be you try, and the only group of people I'd be inclined to mandate would be staff, to say you have to go to at least one open meeting every year or so of at least one mutual aid group, but that is a different matter.
Okay, Eddie?
Personally, I don't know any services that have to mandate people who got a 12-step fellowship. And A, and B, I don't think it would have any effect if it did, because if people want to come in recovery, the willingness has got to come for them. So I don't think you can force any type of recovery on anyone. I know the benefits that we have for the people that we do refer on to fellowships, and it's massive. So I will never waver for that. I'll never waver for what we do at Harbour, for the absence-based work that we do, and the people that we refer on. But it's not just fellowships as well. We refer on to a range of services. And David mentioned physical activities here. We look at the holistic approach as well. So we also offer opportunities. We play pickleball. I love it, by the way. It's a great game. It's North Ayrshire Council gave us some coaching for the guys, one of our groups, and the boys absolutely loved it. They thrived in it. And so we started pickleball groups. We now got one in North Ayrshire, one in South Ayrshire, and 25 people attend and play pickleball every week. It's absolutely fantastic. So I don't really care, David. The truth is, I don't really care where people get well. The reality is, if people surviving, or not just surviving, sorry, people are thriving, whatever they do, I'm all for that. But personally, I believe that the 12-step programme is one of the most successful models that we've got, and I don't see why we wouldn't utilise that. And it might not be for people, but the reality is there's other things that for people that's not want that support.
Thanks, Eddie. Like you, I'm not aware of any services in Scotland that mandate it in any case. So another question relates to input from community pharmacies, and I'll just link this with another question, and occupational therapists. This might have been answered in the chat already. So Eddie, do you have any input from local pharmacies, or have liaison or working relationships with pharmacies and or occupational therapists in the work that you do?
Yeah, absolutely. We get referrals for the occupational therapists all the time. We've also worked alongside the pharmacists as well. We dispense naloxone as well. We use the trainee addiction workers, actually. We get through them trained up for the naloxone training, which I think's an absolutely crucial thing that we use to save people's lives. I think naloxone has saved as many lives as anything that we do, actually. And we're talking about alive to thrive. People need to be alive. So we do use a chemist, and we also go in there and for referring people onto services because they're getting their opiate replacement or opiate OST, whatever they call it now. So yes, we've always used the pharmacy since we started with Harbour.
Okay, thanks, Eddie. And David, what would a recovery-oriented pharmacy look like?
Look, as Eddie says, I'd like to think the kind of contrast or the hostility between harm reduction and recovery is now a thing of the past. So it seems to me like, you pharmacies play a crucial role in early engagement support of people in the acute stages of treatment and in the early stages of support, but they should also be aware of, refer to, and actively engage with any community recovery service. So to the same extent, they should have the number of treatment services in their phones, so they should have the local community recovery worker, and they should be actively championing recovery support, and where possible, using that recovery precedes treatment model of get people who they think are at early stages of harms. As with primary care, get them involved in pickleball or whatever else you might be doing in your recovery community. As for occupational therapists, I think their role is absolutely central. When we talk about, Eddie talked about multiple pathways. When we talk about typically 5 different types of things you want to try and get people involved in: sport, art and recreation, education, training and employment, spirituality and religious groups, volunteering and community engagement, and mutual aid and other recovery support services. Jobs help people. They may not cause recovery, but they're a big marker on the road to recovery, and they can help to get people over the initial hurdles, pay back debts, and give them that kind of routine that allows them. In America, people talk about getting a recovery job in the first year of your recovery journey. Essentially just something to pay the bills that occupies your time, and then you start thinking about careers, vacations, and where you want to go to. And I think that's not a bad way of starting that process.
Okay, thank you. There's been a couple of questions or points made about women in recovery. Eddie, what particular barriers do you think that women find or come across or put in front of them when they're trying to seek support with their alcohol and drug use?
I think if you look at the stats that men and women in recovery, then there's a lot more men in recovery. I think it's 75%, which we generally see. In Ayrshire, it's probably a wee bit different. Probably looking at there's more women, but the challenges that they face are a range of challenges. Childcare could be one of them. A lot of things. I think a lot of women come into recovery as well, and there's a lot of guilt and shame. If they've got kids, there's a lot of guilt and shame about how they think that they've treated their kids, because they don't really understand about addiction, and that it's not really got anything to do with the moral issues that they support. But I think women face these challenges in recovery. But we're lived experience workers through there. We've got 4 women who work with Harbour, who are really supportive. A lot of women's experienced domestic abuse as well. And we actually, when we came in, when we started our first group, we opened a men's group, and then we opened a women's group after that. And the reason for that was because we'd done a bit of research with some services all over Scotland at first when we came in, and the challenges that we were told came up time and time again was mixed sex groups and mixed sex residentials. We're visiting residentials at the time, and you know, there's an obvious reason for that. The first one, when men and women come into recovery early doors, there can be that attraction. But the other reasons David, was that men will not get front. We say it's a West of Scotland thing, but it's not. It's a male thing, that men will not get vulnerable in front of females, and females have maybe been in abusive relationships and they can't get vulnerable in front of males. To get vulnerable, you need to feel safe. So for that reason, we separated the men and the women. We have got a mixed group now because the community wanted that. And in Girvan, we started a mixed group as well, and it's gone really well. But generally, we have kept the women in places where they feel safe enough to come in and recover. And I think that's one of the biggest challenges for women.
Okay, that's really useful and also practical solutions, you know, by giving women safe spaces. David, anything from the sort of research perspective about women's needs not being met?
I mean, the first thing is, look, the SRC, Scottish Recovery Consortium, have done a lot of work in this area, and I think, and I believe they've got an event coming up specifically on that subject. So I think that's really important. Second thing is, one of our team who's doing her PhD at Dundee, Shelley, is a woman in recovery, and she will say she spent a number of years just lying to services because immediately they started talking to her. As soon as she said she had kids, it was all about the child's welfare, not hers. And it actually took her moving out of services, she would say, before she actually was able to start a recovery journey meaningfully, because all it did was have this constant threat hanging over her head. So obviously it's fundamentally different. I mean, the other thing that I think is from the evidence base, the science evidence base, you can say really clearly is if you look at the 12-step stuff, it works just as well as it works for women as it works for men, but it appears to work in a different way. So John Kelly's review of mechanisms suggests that the primary mechanism of action of 12-step groups for men is around changes in social networks. Primary mechanism of action for women is primarily around increasing abstinence, self-efficacy. So not that there's not overlaps and massive overlaps, but look, it's always struck me, everything we've done, life and recovery surveys, everything, women and men recover in completely different ways, and generalising anything from men to women just doesn't make sense, and we need to have a science of women's recovery.
Okay, it's really useful to know. We are running out of time. I've been absolutely bamboozled and distracted by the number of messages in the chat. It's been phenomenal, which is great participation for this event. We've only covered a handful of the themes and questions that have come up, but the ones we've covered, I hope we've covered in some depth and meaning. I'm just going to put to you, you know, we've heard a lot today. A lot of it's been inspiring, a lot of it's been encouraging, a lot of it's been challenging. But the last question is, so what? How are you going to enthuse and mobilise those of us who've been listening to you this afternoon. This has got to be quite short so we finish on time. So in a sentence or two, what message do you want to leave with the participants in the webinar? Eddie, you first. Listen, if I've done my best, if you're not mobilised after that, what you've just seen for what's happened at Harbour, then I'll not be able to mobilise you. But what the message I want to get out in there is, Scotland's a very small country. There's 5.5 million people. A small number of people working together can make a massive difference in our community. We can, working together, whether it's harm reduction, abstinence, statutory service, commission services, NHS, working together can make a huge difference. And I'm all for working for anybody that will help reduce the impact of drugs and alcohol or have in our community. Thanks, Eddie. That's inspiring. And David?
I'm going to be quite contentious here, David, I'm afraid. It feels to me like a recovery model is a fundamentally different model. We've had an addiction industry and an addiction response industry in England and Scotland that has failed repeatedly over years, and tweaking the existing system is not the solution. A recovery-based model that is a fundamental challenge to the way that everybody does things right throughout the system is absolutely essential, because if we keep doing more of what we've done, we'll get more of the same appalling results.
Okay, that is a challenge. Hopefully people will take it up. Thanks to both of you for participating in the chat. I'm going to hand back to Ruth now.
Thank you very much for your presentations and your contributions to that Q&A. I think we probably could have extended you if time had allowed, so genuinely thank you so much, and I hope you get a chance to go back to look at the chat and see some of the comments and reflections. So it's up to me to close off. So thank you again to our speakers, Eddie, Vicky and Megan, Professor Best and Dr McCartney. Really appreciate your time you've taken out your day to contribute and help empower us all. Thank you for all joining us, and the contribution in the chat's been great to actually observe and participate in. And thank you to the team behind the scenes who bring this all together and make it happen. So some final reflections for me. Scottish Government have asked us to share some newly launched learning materials that are available to everybody in Scotland for the drug and alcohol workforce resources. So they'll be in the chat and they'll be available to you. Please save those links and pass them around your networks and make sure that you get best use out of them. On your screen at the moment, you'll already see a poll that's popped up, and we're just keen to get some answers from you about your reflections of the sessions and anything to take away. That just helps us design future sessions. We are also really interested in understanding those of you out there who want to join a recovery network as part of Health Improvement Scotland. We're really keen to make sure that we connect nationally and make sure that we can try and encourage and develop some of the policy that's coming out of Scottish Government post-mission. So if you're interested in that, there is a forum in your chat, please sign up. And we'll gauge interest. If we get lots of people who are really up for it, then we'll set up something and be back in touch with you all. After today's session, we will send you out the link to the recording and the presentations and the materials, and we'll do a short write-up just to kind of encapsulate the conversation. Thank you so much for all of your contributions today. It's been a fantastic session to be part of and to observe and hear so much opportunity and potential and all of this in relation to recovery. And I absolutely think that the points have been well made, that Scotland's a small place and there is a movement happening, and it's up to us to do as much as we can to make that a reality and help lots more people get better and to thrive. So a massive thank you from me and from all us at Health Improvement Scotland, and we'll be in touch with you about future events, and I hope you enjoy the rest of your day. Thank you so much.